Hello and welcome to ASC's Guideline Webinar Series. I'm Melissa Lawrence, ASC's Manager of Education and Products. Today's webinar is titled Guidelines for Performing a Comprehensive Transesophageal Echocardiographic Examination in Children and All Patients with Congenital Heart Disease, Recommendations from the American Society of Echocardiography. Without any further delay, let me introduce you to today's speaker. Dr. Michael Puchalski is the Director of Non-Invasive Imaging in the Division of Pediatric Cardiology at the University of Utah School of Medicine and Primary Children's Medical Center. He is responsible for overseeing the Fetal Heart Program, the Echocardiography Lab, and the Cardiovascular MRI. Dr. Puchalski is also the Medical Director of Outpatient Services in Riverton. He sees children with all forms of congenital cardiac disease and pregnant mothers in whom there is concern for heart disease in the fetus. His special interest is in advanced cardiovascular imaging. It is our pleasure to have Dr. Puchalski with us today.
Good morning, everyone. Thanks for signing on. I'm going to sort of jump right in here. And we're going to talk about the echocardiographic evaluation of children and all patients with congenital heart disease, which is based on structures rather than views. And the reason for that is there's a tremendous amount of anatomic variability in congenital heart disease. So these views need to be modified, but really serve as a starting point. In congenital heart disease, we desire longer clips and sweeps. And for any abnormality, we recommend using 2D color flow and spectral Doppler in multiple views, and we'll talk about 3D where it's appropriate. What I'm hoping to cover today is the indications and absolute and relative contraindications of the transesophageal echocardiogram, characterize the role of TE in the OR and during percutaneous interventions, review the differences between the 28 views for congenital heart disease patients as well as, or in comparison to the 28 views from the adult guidelines, and discuss the application of TE to specific congenital malformations, again, including 3D where appropriate. The flow of this webinar is going to be as if you're reading the document from beginning to end. So I'm going to show tables and figures followed by key points which are spread throughout the document until I get to the structural imaging section, and then I'm going to flip that around and talk about the key points first, and then show examples of each section. So for indications, there are diagnostic indications which are, primarily related to suspected congenital heart disease when the transthoracic echocardiogram is non-diagnostic. Presence of a patent foraminal valley with or without agitated saline contrast to assess direction of shunting for an etiology of stroke, evaluate the cardiac source of an embolus when there's no identified non-cardiac source, evaluation of intra or extracardiac baffles following the Fontan, Senning, or Mustard procedure, suspected acute aortic pathology, including but not limited to dissection and transection in Marfan's bicuspid aortic valve and coarctation, intracardiac evaluation for vegetations or suspected abscesses, evaluation for intracardiac thrombus prior to cardioversion for AFib or fib or radiofrequency ablation, pericardial effusion or cardiac function evaluation and monitoring a postoperative patient with an open sternum or poor acoustic windows, evaluating the status of prosthetic valves in the setting of inadequate transthoracic imaging, and reevaluation of prior TE findings for interval change. Perioperatively, immediate preoperative definition of cardiac anatomy and function is done in all of our patients. Postoperative surgical results and function after surgical cases. Intraoperative monitoring of ventricular volume and function is done in some non-cardiac cases, and then monitoring of intracardiac and intravascular air or adequacy of cardiac de-airing towards the end of bypass. In the cath lab, TE guided interventions for the placement of occlusion devices, namely septal defects or Fontan or intraatrial baffle fenestration closure, guidance for balloon or blade atrial septostomy, guidance for creation or stenting of an intraventricular communication, during percutaneous valve interventions or radiofrequency ablation procedures, assessment of the results of minimally invasive surgical incision or video-assisted cardiac procedures, and guidance during placement of catheter-based cardiac assist devices like the Impella heart pump. Contraindications, there are some absolute and relative. So absolute is the unrepaired tracheoesophageal fistula, as you wouldn't be able to get in the appropriate position, esophageal obstruction or strictures, perforated hollow viscus, an active gastric or esophageal bleed, if you have poor airway control, if there's severe respiratory depression, or the patient is uncooperative or unsedated. And then relative contraindications, a history of esophageal or gastric surgery. We have an evaluation by our general surgeons if that has been done in the past to clear the patient. If there's a history of esophageal cancer, esophageal varices or diverticulum, a recent GI bleed, active esophagitis or peptic ulcer disease, vascular rings or an aortic anomaly with or without compromise, oropharyngeal pathology, a severe coagulopathy, significant thrombocytopenia, a cervical spine injury or anomaly, or post-gastrostomy or funduplication might limit the imaging. So key points for indications and contraindications. Indications for TE in all children and all patients with congenital heart disease include pre- and post-operative evaluation of cardiac anatomy and function, guidance of transcatheter interventions, non-diagnostic transthoracic imaging, intracardiac thrombus, prosthetic valve function, and the diagnosis of infective endocarditis. And the benefits of the procedure should outweigh the risk when patients with relative contraindications are evaluated for transesophageal echocardiograms. Relative contraindications primarily relate to the potential of esophageal trauma or airway compromise, as we just reviewed. We also covered training and certification in the document. So our feeling here is that you need to be an expert, essentially, at echocardiography and primarily transthoracic imaging for 6 months or more, with a minimum of 450 cases across all age groups before you begin transesophageal imaging. Esophageal intubation and practice with insertion should be in 25 cases, with half of those being less than 2 years. And then for the exam itself, one should perform or interpret with supervision 50 cases. Ongoing TE experience or the maintenance and competency should be done on an annual basis, 25 to 50 cases per year, or some centers may have lab-established standards or outcome variables that allow you to have less than that if there are a number of physicians at your institution that perform TEE. So for key points, physicians wishing to perform transesophageal echocardiogram in children and all patients with congenital heart disease should receive supervised training and interpretation by a practitioner with significant TEE experience. That person can be a pediatric echocardiographer, a congenital cardiovascular anesthesiologist, or an echocardiographer with experience and or training in adult congenital heart disease. One should undergo supervised performance and interpretation of at least 50 TEE exams in pediatric and or adult congenital heart disease patients prior to independent TEE imaging. Importantly, there is no current certification pathway specifically designed for physicians performing TEE for the pediatric or adult congenital heart disease patient. For patient selection and complications, TEE demonstrates a favorable safety profile and low complication rate in children and all patients with congenital heart disease. Most complications are related to respiratory compromise or vascular compression. There are rare serious complications which include esophageal perforation, gastric laceration, or subglottic stenosis. And while general anesthesia is typically employed for the performance of TEE in children, TEE in the adult with congenital heart disease is routinely performed with conscious sedation. Anesthesia assistance should be considered in the adult with Fontan physiology, unrepaired or palliated cyanotic cardiac lesions or severe pulmonary hypertension. We covered probe care, and I'm not going to go into this in detail, but it is in the document about the appropriate way to take care of your transesophageal imaging probe. The probe selection is primarily based on patient weight and probe size. So for pediatric 2D TEE probes, they are available as a micro multiplane probe and are used in patients greater than 2.5 kilos, and a mini multiplane probe, which is greater than 3 to 3.5 kilos. The adult 2D and 3D TE probes are available for use in patients over 25 kilos and 30 kilos, respectively. But in clinical practice, each probe has been used safely below these weight recommendations. TE probe insertion should be performed with adequate sedation or anesthesia and after an appropriate period of fasting, and careful monitoring for complications is essential. The TE probe rinsing and high-level disinfection should be performed after each use according to manufacturer's instructions and institutional policy. So for probe position and manipulation, this diagram is used also in the adult guideline because it's really the same sort of movements and position. So on the left-hand side, we talk about throughout the document of advancing the probe in or withdrawing the probe out, and then rotating forward, which is from 0 degrees to 90 degrees to 180, or rotating backwards, so 180 to 90 to 0. You can also anti-flex or retroflex the probe, as well as moving it right to left. And then on the left-hand side, the main positions to acquire images for transesophageal imaging is in the upper esophagus, the mid-esophagus, the transgastric plane, and then the deep transgastric, and we'll review these in detail. For the image display, on the right-hand side, the patient's right and then the patient's left when you're at 0 degrees. And then as you move to 90 degrees, inferior is on the right and anterior is on the left. And then the panel on the right there is when you go to 180 degrees, everything is inverted from the 0 degree plane. So getting into the views themselves. So we elected to have a similar format to the adult guideline, which shows each view in its imaging plane on the left-hand side, then a 3D model showing you where that image plane is obtained from, followed by the 2D transesophageal image, and then the acquisition protocol focusing on the transducer angle to obtain that image and the level at which you obtain it. And then on the far right-hand side, where we document which structures are imaged within that view. The title of each of these was an abbreviation, and the full name is in the text itself. We flipped these two views from the adult document. So we have the mid-esophageal 4-chamber view as our home view, whereas in the adult document, that was the second image. So we put the 4-chamber first and call it sort of our home base. You obtain this view at 0 degrees, sometimes 0 to 10 degrees. And again, attached are all the structures you can see: the left atrium, right atrium, the interatrial septum, the left ventricle and right ventricle, and the interventricular septum, the coronary sinus, tricuspid valve, mitral valve. The second view is the 5-chamber view, which you obtain by tipping up into the left ventricular outflow tract, and so you can pick up the aortic valve and the left ventricular outflow tract by antiflexing the probe slightly. The next about 7 or 8 views are all the same as the adult paper. So mid-esophageal mitral view is the mitral commissural view. You obtain that by rotating the probe forward between 50 and 70 degrees, and then you get the mitral valve there in the center of the picture, looking at these scallops or from the posterior leaflet to the anterior cusp against the posterior. And then in the two-chamber view, subsequent view, you rotate a little further forward to 80 to 100 degrees, and again, pick up those structures that are listed on the right-hand side. So for the mid-esophageal long axis view is the fifth view. You're rotating again forward, this time to 120 to 140 degrees, and you have really beautiful pictures of the left ventricular outflow tract and the aortic valve there. You can rotate clockwise to get the right ventricular outflow tract as well in this view. And then the sixth view is the aortic valve in long axis, which is obtained by withdrawing the probe a little bit at the same 120 to 140 degrees, and then narrowing your depth or focusing in on the aortic valve itself. Our seventh view, the ascending aorta long axis view, is rotating back towards 90 to 110 degrees, and then rotating your probe to the left to get the ascending aorta, and then posterior to that is the right pulmonary artery. If you, on the eighth view for the ascending aorta in the short axis, so you rotate back to 0 to 30 degrees, still in the mid-esophageal plane, and you get the ascending aorta in cross-section, and you start picking up the main and branch pulmonary arteries. Usually you can get the right pulmonary artery pretty well here in just the proximal portion of the left pulmonary artery. The ninth view is the right pulmonary veins obtained at 0 degrees, rotating your hand clockwise or to the right, and you can pick up pulmonary veins entering the left atrium. You can get both the right lower and right upper by advancing and withdrawing the probe. The 10th view is the left pulmonary veins view, and this is different than the adult guidelines where they combine the right and left pulmonary veins in this view. We're saying the best view for the left pulmonary veins here is to go between 90 and 110 degrees and rotating counterclockwise to pick up both the left upper and left lower pulmonary vein, again by advancing and withdrawing the probe. Sometimes you can get them both in the same picture. You can also obtain the left pulmonary vein view at 0 degrees by rotating all the way to the left or counterclockwise. The 11th view is the left atrial appendage view. In the adult guidelines paper, I think this is view number 15. We just adjusted the order. In this view, you see the left atrial appendage and the left upper pulmonary vein here coming in just over the top of the left atrial appendage. The mid-esophageal aortic valve short axis view is the next view obtained at 25 to 45 degrees, and this shows you each cusp of the aortic valve, and sometimes with slight manipulation or withdrawal of the probe, you can pick up the proximal left coronary artery and right coronary artery. For the 13th view is the mid-esophageal RV inflow and outflow view. This is obtained at 50 to 70 degrees and is a really nice view of the right ventricular outflow tract. You can also pick up some of the main pulmonary artery in this view. The 14th view is the modified bicaval tricuspid valve view, and you obtain this by turning the probe clockwise from the RV in and outflow view, but at the same angle. So you just rotate your hand a little clockwise and position the tricuspid valve in the center of the screen there. And you can also get the IVC and the SCC in this view. And then the bicaval view is rotating to 90 to 110 degrees, and you see the superior vena cava coming down from the top of the screen and the inferior vena cava at the bottom of the screen. and this is a really good view to evaluate the intraatrial septum. Then we move to the transgastric views. We added view number 16 here, which we're calling the IVC hepatic veins view. We primarily did this because we have lots of patients that have abnormal inferior vena cava or abnormal hepatic venous drainage, and this is a good view for that. For the, in comparison to the adult guideline paper, we did not use RV basal, RV in and out, or RV inflow views, so we removed those views for our guideline. We did keep the same, the transgastric basal short axis view here, which is a good way to evaluate ventricular function. Similarly, the 18th view or mid-papillary short axis view, these are both obtained from 0 to 20 degrees and just advancing or withdrawing the probe to obtain these accurate planes. Again, advancing a little bit more, you can get an apical short axis view at the 0 to 20 degrees to evaluate the apex of both the left and the right ventricles. And then rotating into a long axis plane from this transgastric position at 120 to 140 degrees, you can get the left ventricle and left ventricular outflow tract as well as the aortic valve. For moving to the deep transgastric views, so we flipped these deep transgastric views from the adult guidelines and have them rotated such that the apex is at the bottom of the screen. And the 5-chamber view is similar to the adult guidelines. Is a really good way to evaluate the left ventricular outflow tract again. And then we added the right ventricular outflow tract view, given that we have a lot of patients with conotruncal abnormalities, and you just rotate your hand a little clockwise at an angle of 50 to 90 degrees to get the right ventricular outflow tract. We also added view number 23, which is the atrial septal view, and you see the SVC at the top of the screen coming down in the IVC, and this profiles the atrial septum well, as we have a lot of patients with atrial septal defects that need closure. And then moving to the upper esophageal views, this is similar to the adult paper. At 0 degrees in the upper esophagus, you get the ascending aorta and some of the aortic arch. Rotating to 70 to 90 degrees, you can get the aortic arch in short axis, as well as the main pulmonary artery and even the pulmonary valve in this view. And then we added view number 26, which is an upper esophageal pulmonary artery view, again, because a lot of our patients are having surgery in this area. For me, again, you see the right pulmonary artery typically very well in this view, but the left pulmonary artery only the proximal portion. And then finishing out, our last two views are the same as the adult guideline paper, the descending aorta in short axis, as well as the descending aorta in long axis. So the first one at 0 degrees, and then rotating 90 degrees, and you can lay out the descending aorta in a long axis projection. So briefly on 3D, the way that we handled 3D is we sprinkled this throughout the document. So 3D TE has been recommended for ASD device closure as well as VSD device closure. We use it for visualization of catheters or delivery systems and devices. We can measure defects on FASE, and I'll show some pictures of that. You can assess anatomy and function of the atrioventricular valves, as well as visualization of the aortic valve and left ventricular outflow tract to assess the difference or distance from a VSD to the outflow tract to help the surgeons for baffle closure of a VSD. 3D has also been used effectively for Fontan fenestration closures, ruptured sinus of Valsalva aneurysms, coronary artery fistulas, prosthetic valve, perivalvular leak device closure, atrial switch baffle leak device closure and baffle obstruction stenting, transeptal puncture during various procedures, as well as biventricular pacemaker synchrony assessment or lead placement guidance. So for the key points for this section, we recommend a series of 28 tomographic views be used to perform a comprehensive TEE exam in children and all patients with congenital heart disease. The views are obtained from 4 primary positions within the esophagus and stomach: the mid-esophagus, the transgastric, the deep transgastric, and the upper esophagus. All views are presented with the standard apex up orientation, except for the deep transgastric views, which are inverted to an apex down position to present an anatomically correct display. These views serve as a starting point for congenital heart disease evaluation and can be altered as needed. The exam should be structure-based, not view-based, and include a minimum of 2D color flow and spectral Doppler from multiple views. 3D TEE imaging can be performed in conjunction with 2D in patients greater than 30 kilos and involves the use of specific 3D techniques, including adjustable sector, full volume, and live multiplane methods. And Table 6, as we reviewed, lists a number of clinical uses for 3D TEE, and the protocols for that are in the document. For size and function, we recommend the transgastric short axis views in children because the long axis view does not account for lateral motion of the LV, which is seen in many kids. LV systolic function is generally assessed qualitatively, but can be quantified with linear shortening fraction and 2D, 3D volumetric ejection fraction. Assessment of the right ventricle size and function is generally assessed qualitatively, but 3D volumetric programs do allow for quantitative assessment. So I'm going to switch gears or format here just a little bit because I'm going to start showing examples of a bunch of different things. In the structural imaging section, we start out with primary causes of mitral valve dysfunction, which include congenital abnormalities as well as myxomatous changes or infectious damage from endocarditis or inflammatory disorders. The mid-esophageal views, primarily 4-chamber, 5-chamber, mitral, the 2-chamber long axis, and even the aortic valve in the long axis, are most helpful to delineate mitral valve anatomy and physiology. But you can also use transgastric and deep transgastric for some of the more complex congenital patients. Color flow and spectral Doppler aids in return to bypass decisions following mitral valve repair. So here's a look at the mitral valve from a 3D plane. On the right-hand side, you have like a multiplanar view, and then on the left-hand side, the anterior and posterior valve leaflets here are seen nicely. For assessment of the aortic valve complex, that includes the left ventricular outflow tract, the aortic valve itself, the aortic root, and the supravalvular region. Both mid-esophageal short axis and long axis views can provide complete evaluation of the aortic valve and the left ventricular outflow tract. I often find the transgastric long axis or 5-chamber views are also helpful as you're really well aligned for pulse wave or continuous wave Doppler gradients. The ascending and descending thoracic aorta are best visualized systematically using a combination of the mid-esophageal and upper esophageal views at different levels of the esophagus. So here's a look at the normal aortic valve on FASE. This is a bicuspid aortic valve with fusion of the left and right cusp, and here it is with the right and non-cusp. That's a unicuspid aortic valve showing a really small effective orifice, and we're back to the normal aortic valves shown beautifully here by 3D. This is a patient where we're in the aortic valve long axis view and you have the mitral valve up here with the aortic valve right here. And just above the aortic valve in the ascending aorta, you see this narrowing coming from both sides, which is consistent with a patient with supravalvular aortic stenosis. So again, narrowing here with the dimension smaller than the aortic valve or the ascending aorta. So for tricuspid valve abnormalities, they may be anatomical, such as Ebstein's anomaly, or tricuspid valve dysplasia, stenosis, pacemaker lead-induced non-coaptation. You can have a flail leaflet. You can have straddling or overriding in some of the complex congenital heart diseases, or it can be due to problems with the left side of the heart. And the mid-esophageal views typically provide the best assessment for tricuspid valve morphology and function. So here's a tricuspid valve in 3D, the anterior leaflet, posterior leaflet, and septal leaflet here. And this is shown from the right ventricular side. This is a patient with Ebstein's anomaly of the tricuspid valve. Here's the plane of the mitral valve, and this up here is where the tricuspid valve should be, but you have downward displacement of this tricuspid valve septal leaflet, such that the coaptation is down here, and that's where you see the regurgitation coming from. So this is all plastered septal leaflet along the ventricular septum, with the coaptation point being down here. This is the functional right ventricle right down here at the apex. And this up here, where I'm circling, is all of the atrialized portion of the right ventricle here, and then the right atrium up there. So for the pulmonary valve complex, that includes the subvalvular, valvular, and supravalvular regions as well. You can obtain views of this in the mid-esophagus, the deep transgastric, as well as the upper esophageal views, and color and spectral Doppler is really important to evaluate the degree of stenosis and regurgitation across this area. And then 3D, I've been sort of sprinkling through these pictures to give you a better assessment of size and the mechanism of dysfunction. I have one look here. This is a patient with tetralogy of Fallot, where you have a normal appearing tricuspid valve. Here's the right ventricle, and then you have this prominent infunibular muscle that is in the right ventricular outflow tract here, making this narrowed below where the pulmonary valve would be up here, and the pulmonary valve looks a little dysplastic, although it's not opened particularly well, and the aortic valve is here in the center of the screen. So moving on to the atria and systemic and pulmonary veins, you can determine atrial situs by evaluating the atrial appendages as well as key systemic venous structures. And while the mid-esophageal views are most commonly used, all the positions should be used or employed when there are questions. T can identify unusual systemic venous anomalies, such as an LSVC to coronary sinus, or if it drains directly to the left atrium. You can evaluate interrupted hepatic veins, as I showed from that transgastric view, as well as atrial anomalies such as juxtaposed atrial appendages or cor triatriatum. T provides excellent visualization of normal left and right pulmonary venous return and enables accurate pulmonary venous Doppler assessment, which can be utilized to evaluate stenosis of individual veins or within the pulmonary venous confluence. T can also be used to evaluate partial or total anomalous pulmonary venous return. However, with the latter, care must be taken because hemodynamic compromise has been described with TE probe insertion and manipulation. So when the pulmonary venous confluence sits behind the heart, and then you put the probe in the esophagus, which is also behind the heart, you can cause some compression of that pulmonary venous confluence, which may make patients worse. Here is a picture of the left atrial appendage here with the left upper pulmonary vein coming up over the top of the left atrial appendage. and there's turbulent flow right as it enters the left atrium. And you can Doppler in there to see what the gradient is of that individual vein. This is a picture of a patient with cor triatriatum. This is the left atrial appendage again here, and then you see the membrane starting just above the atrial appendage and coming all the way across over to the atrial septum. And on the right-hand side, in this color compare mode, you see that there's turbulent flow that is below this cor triatriatum membrane. What differentiates cor triatriatum from supravalvular mitral rings is the supravalvular mitral rings are located within the annulus itself, whereas the cor triatriatum membrane is located above this left atrial appendage. Moving on to atrial and ventricular septal defects, I'll show you a bunch of subtypes of secundum ASD in a second, as well as the different types of ventricular septal defects. T plays an important role in monitoring of ASD and VSD device closures in the cath lab. It's important for postoperative assessment of VSD closure, especially for determination of significant residual VSDs, outflow tract obstruction, and aortic regurgitation, as it helps us determine whether to return to bypass. T is indicated preoperatively in essentially all patients with an atrioventricular septal defect or AV canal, but particularly in the older infant and child in whom surgical decision-making might require delineation of the degree and the mechanism of AV valve regurgitation, the outflow tract obstruction, and or suitability for biventricular correction itself, and whether or not the AV canal is balanced or unbalanced. And 3DT is very useful for assessment of the ASD and the VSD in these conditions, as well as the atrioventricular valve itself. So here is a diagram of different types of atrial septal defects. Up here is a sinus venosa superior vena cava type defect. This is often associated with anomalous drainage of the right-sided pulmonary vein. The secundum atrial septal defect is the most common. This is also where a patent foraminal valley would be located. Here's the primum atrial septal defect, which is seen in patients with atrioventricular canal. You can have an unroofed coronary sinus, and a sinus venosus IVC type is located here and is actually pretty rare. For ventricular septal defects, again, an inlet VSD here goes along with atrioventricular canal. You can have muscular VSDs in multiple different locations. The perimembranous ventricular septal defect is located here, and an outlet ventricular septal defect typically is up here underneath the pulmonary valves. Here are a few pictures by 3D. This is of an atrial septal defect here, which is shown beautifully on FASE. And this particular video shows the catheter. This is for a device closure. So the catheter goes through the hole. The left-sided disc is open and pulled through, and then the right-sided disc is released. And you see it nicely laid out here along the atrial septum. There's a little bit of leak through the device itself, but that usually closes on its own. And then over here on the right-hand side, you see a ventricular septal defect with the aortic outflow up here, shown really nicely here, the aortic valve and the defect. This is the left ventricle and the ventricular septum here. This is a picture of a balanced atrioventricular canal where you have a primum atrial septal defect up here, and then a large inlet ventricular septal defect here. This is the crest of the ventricular septum. And then there's one AV valve that spans all the way across both the left ventricle and the right ventricle. So for coronary arteries, imaging of the coronary artery origins is primarily done in the mid-esophageal short axis views, and demonstration of an anomalous coronary origin from the opposite sinus of Valsalva requires really careful interrogation with both 2D and color Doppler. In anomalous left coronary artery from the pulmonary artery or anomalous right coronary artery from the pulmonary artery, the anomalous origin of the of the coronary artery from the pulmonary artery can be visualized using mid-esophageal views. One can also oftentimes see segmental wall motion abnormalities or ventricular dysfunction, and mitral regurgitation should be carefully assessed for. Here's a patient with the aortic valve on FASE in the center of the screen here. It looks like the left coronary artery is coming off in the normal position, but with color you see that it's actually coming off the right sinus and tracking behind the aortic valve as it moves over to the left, and we'll play it again. But it's coming off from the right there, again tracking behind the aortic valve and moving over towards the left. So this is an anomalous left coronary from the right sinus. For conotruncal defects, these include tetralogy of Fallot, double outlet right ventricle, truncus arteriosus, transposition of the great arteries, both D and L, or we also call that ventricular inversion. Anatomic assessment should include the great artery position, whether it's anterior, posterior, or medial lateral, as well as conoseptal location, subpulmonary, subaortic, or underneath both, and then the position of those great vessels and the size, and whether or not they're small or atretic or absent. Associated VSDs can be classified as subaortic, subpulmonary, remote, or doubly committed under both the aortic and pulmonary valves. For all conotruncal defects, TE allows for pre- and postoperative evaluation of outflow tract patency and obstruction, residual VSDs, residual atrial level communications, AV valve or semilunar valve insufficiency and function. 3D TE can be used to provide further clarification of the VSD and the outflow tract anatomy, as well as the semilunar valve morphology and function. And where applicable, intraatrial baffle obstructions or leaks can also be evaluated. Here's a patient with double outlet right ventricle. We're really just focused on the aortic valve here overriding the both ventricles, so left ventricle, right ventricle, and a large ventricular septal defect here. With color, you see flow from both the right and the left exiting the aorta. You get a hint of a smaller pulmonary valve here in the background, or a smaller main pulmonary artery. This is a patient with transposition of the great arteries who had a baffle. This is the baffle here bringing the blue blood over to the left side because the right ventricle the left ventricle is here, but this is not an arterial switch. This is an atrial switch. So you have to bring the blue blood over to the left in order to get it out to the lungs. And then over here on the right-hand side, this up here at the top of the screen shows the pulmonary venous baffle. So you're bringing the pulmonary veins that are coming back from the lungs and baffling that over to the right atrium and subsequently to the right ventricle, because the aorta is coming off the right ventricle. So you're taking oxygenated blood over to the right to be delivered to the body. So for single ventricles, the role of TE in complex single ventricle depends upon the underlying anatomy and also the stage of surgical palliation. So we can evaluate the Damas-Case-Stanzel or the Norwood procedure, as well as the modified BT shunt and or Asano, a superior cable pulmonary anastomosis or the Glenn procedure, as well as the total cable pulmonary anastomosis or Fontan procedure. The DKS is best viewed from the mid-esophageal aortic valve long axis, and I'll show that. Visualization of the shunt can oftentimes be difficult. A BT shunt, but the Sano is usually easily seen. Visualization of the Glenn is often difficult, but you can usually see its entrance into the branch pulmonary arteries. And T in the Fontan patient is actually pretty good and allows for assessment of thrombus or residual Fontan fenestration, as well as AV valve function and ventricular function. Interventional device closure or creation of a Fontan fenestration can be guided by both 2D and 3D TEE. Here's a patient with a hypoplastic left ventricle. So here's a normal right ventricle that's wrapping underneath this small and poorly contractile left ventricle, and all the flow is coming through the atrial septal defect over here to the right ventricle. And on the right-hand panel, this is a really nice connection of the ascending aorta into the main pulmonary artery, what we call a damus connection. And you see by color that there's no obstruction to flow as from the damus into the main pulmonary artery there. This is a picture of an unbalanced atrioventricular canal. I just wanted to give you a comparison that the right ventricle here is much larger and the AV valve is committed more towards the right ventricle than it is the left ventricle. And you really see minimal flow coming from the atria, which there's no atrial septal, there's no atrial septum really seen here. But all of that flow comes over to the right ventricle and very little into the left. So the end of the document is a table which reviews all the things that we covered from a congenital heart disease standpoint within the text. And basically it goes through each defect and gives you where to assess the lesion and in what view. And then on the right-hand side, commonly associated lesions and how to obtain those views. I'm not going to go through all of these in detail, but I do think that this was an attempt by us to allow this to be a really quick reference guide for you when you go into the operating room. And you can see here, if you have a patient with a conotruncal defect or something, you can take in this section and identify which views to get to that are going to give you the best view of great artery position, for instance, or the conoseptal location, or the size of the VSD. And then over here, corresponding views looking at AV valve abnormalities or size and function. So tetralogy, double outlet right ventricle, truncus arteriosus, where to get for the arterial switch procedure, and the Lecomte, a Rastelli procedure, atrial switch, which I showed you a couple pictures of, or ventricular inversion or LTGA with both physiologic repairs and anatomic repairs, and then the single ventricles that I just covered and the different surgical types. So in conclusion, there is a tremendous amount of anatomic variability in congenital heart disease, so views need to be modified and really serve as a starting point for investigating the abnormalities. Again, we've talked about this, but congenital heart disease is really based on structures rather than views, and longer clips and sweeps are essential. For any abnormality, we recommend 2D color flow and spectral Doppler in multiple views, and using 3D where appropriate. Thanks very much. It looks like I have one question that I see, and the question was, are the guidelines committee working on an updated pediatric transthoracic guideline that will include 3D imaging? There was a 3D imaging guideline paper that came out a few years back. And usually, I'm not sure what the time frame of redoing that is actually. It's something that is discussed at the board level. But the ones that came out a few years back, I think, will be the guidelines for at least another few years.
Alrighty, well, if there aren't any additional questions, we can go ahead and end today's session. Thank you, everyone, for participating in today's webinar, and a very special thank you to Dr. Puchalski for presenting on behalf of ASE. Be sure to keep up to date on future live webinars by checking the ASE University homepage. Thank you, and have a great day.